I'm going to make Helen the host because I've got to log off.
Okay.
Good luck, everybody. Have a good meeting.
Thank you, Paris.
Thank you.
Okay.
Thank you
Helen,
for helping out.
the host. So you should have all the controls.
Yes, I think I have.
Yeah. Okay. Good luck, everybody.
Thank you.
Thank you.
Abis sudah ka meeting Bladder Nah, ada ba yang SCI yang Dr. Abang punya hari ini ba?
So we might ask everyone just to mute themselves while we're waiting for people to join in, just so we don't get a lot of background noise, please.
Helen, if you want, you can manually mute somebody by just hitting the 3 blue buttons on their box and hit mute.
By hitting the what, sorry?
So if you scroll over there, the person's icon, I think it's DK Mazira, there's a little blue box with 3 dots, you could hit mute.
Previously ada ba?
Beautiful.
There we go.
That's quiet now. Okay. Thank
All right,
you.
good luck.
Thanks. So we'll just give people a few more minutes to log on. But thank you all for joining us tonight. This is the first time we've tried to do a Zoom meeting as part of this MOOC that we're all so enthralled with. The MOOC platform itself doesn't have the ability to do this, so I had asked Paris from Hollister if he could help us out and loan us his account, and he did, thankfully. So we'll try and record it. Well, we are recording it so we can share it with people later on. I'll just introduce a few of us first. So I'm Helen Craft. I work in South Australia. I'm one of the admins and on the ISCOS Nurse SIG committee. We've also got Randy here. Randy, do you want to introduce yourself?
Yes. My name is Randi Stensgaard and I'm from Denmark, and also been a part of the special interest group for nurses in ISCOS, and also a part of the admin for this MOOC. I'm sure you've seen both Helen's and my name on many letters by now, so so happy to be a part of this.
Veronica, would you like to introduce yourself? You're muted still.
Good morning, together from Germany. I'm also a part of the SIG nurse group, and I'm responsible for the part of the bowel management, and I'm happy to be here this morning.
I don't think we've got Letitia here, so we haven't got the full team, but we have got Tracy, and Tracy will introduce herself. She's kind of the host of the topic tonight. We're looking at the bladder module, so she's hosting that. We're hoping you've got some questions. There was only a couple that came up on the contact us page on the MOOC site, but someone had some really good comments to make, so we'll run through those. Other than that, if you want to speak, if you pop your hand up, which is under reactions, I think. Is that under reactions? I can't see it.
Yes, it's under reactions.
Okay, so pop your hand up and then we'll get to you, or use the chat feature as well if you want to type things in. You can all put your cameras on if you want so that we can see everybody. We are still having some on and off little problems with the MOOC. We're learning and working our way through. I don't think Randy or I have ever done so much IT kind of computer stuff ever before. But we're getting there. We'll be experts at the end, and next time we run this, it will all be perfect. So I'll hand over to Tracy now, and she's going to get the ball started. Tracy, I think I sent you that list of questions earlier. Did you get it?
The one I just got, the one from Gemma.
Yes.
Sent. That's
Cool.
okay. I'm Tracy Tatum. I'm also part of the special interest group of nurses for ISCOS. And I've had a big focus on bladder management. So I put together a couple of slides in relation with some links and some articles and everything like that in relation to the bladder management. After you completed your e-learning and doing the self-assessment quiz in the e-learning for bladder management, and listening to some of the stories in that section as well, the patient perspective. And I have worked in I work in spinal injuries unit in Brisbane, Australia. Queensland, Helen keeps reminding me I'm in the tropics, so I'm a bit sweaty sometimes. But otherwise, I've been working here on and off for about maybe 30 years. And I have been here for the last 20 years, definitely 20 years straight here in the spinal unit. So hopefully, if you want me to start, Helen, with addressing some of Gemma's questions, I have a funny feeling that I actually know her. Her question is that she's noticed that some patients with the T10 level have had some issues with the catheter insertions, especially at the internal sphincter. She said one of her senior colleagues had mentioned that the micturition center is at about T10. And she's surprised that this learning hasn't covered this. Most of my learning with the micturition center, not that it's referred to much nowadays, is usually that it's actually in the brain, and that assists with the coordination in an able-bodied person if all the nerve reflexes and everything like that are present. If there's issues at about T10 or with that level, most of the nerves below that level are the ones that are actually involved in the actual voiding process. The pudendal nerve, the pelvic nerve, the hypogastric nerve, the pudendal and hypogastric, I think around the S2 down to S4. And basically, I think the pelvic nerves and everything branch out from about T11, T12. Depends on the type of injury that's involved. In relation to insertion of a catheter with the sphincters, a lot of that may be we've had issues, it doesn't matter what level that they have with the insertion with the sphincter. A lot of it has to do with spasm. It's not necessarily in relation to the bladder. It is just the automatic response of anything being foreign inserted into the bladder. The sphincter wants to slam closed because that's the normal, well, it's a normal body response, whether they can feel it or not. And similarly with the nerves, it doesn't necessarily matter whether the message goes through to the brain or not. So if Gemma's had some issues with the paraplegics at T20, I've had various nurses at various times, it's not always predictable, may have problems with the insertion of the catheter, and a lot of it is to do with spasms around that area. Did anyone have any other comments about that? And I know our urology nurse based up in the urology ward here seems to think that it is definitely very specific with people with a spinal cord injury to have that problem at the sphincter muscle.
Tracy, I can't say that I've noticed it specifically at T10. I do notice when people are having that trouble getting it in, but then I've never studied to look at the different levels of it. I think it would be good to do that maybe and just see if there is something specific. But it was interesting. Yeah. There's a whole range of other reasons. If you've got a big prostate sitting in there somewhere or a bit of a false passage, but that was interesting about the T10. So maybe we could pass that on to our questioner to see if she'd like to do a bit of research for us.
Yes, it sounds like a good idea.
Gus has a hand or had a hand.
Hi everyone.
Hi.
I'm RN from Western Australia. Thank you so much for putting this up. Great resource. brilliant. I've been just getting my head around all of it. I've noticed that different issues like with bowels, like constipation or even just the normal spasms from the body can be quite hard, especially comorbidities or like people that have a bit of a gut, sort of have to push it up. And yeah, I found that prepping everything so that the old one comes out and then the new one comes in without letting that sphincter relax, sort of makes the job a lot easier.
Yeah, we hit the bellies that get in the way, and we get the things that kind of retract back, and you've got to try and grab them. Lots of interesting anatomical challenges.
We've recently had where we couldn't actually get the catheter out a couple of times, especially with the ones, they have been paras, they haven't been as low as the T10, but the severe spasm with everything just clamping down, and you have to wait and maybe rely, we've had to use Valium actually to relax the sphincter because we had no choice. It had been an hour and we still couldn't get the catheter out, so yeah.
Tracy, do you want to look at some of...
Can I just make a comment? Sometimes it helps to ask the patient to cough. Have any of you experienced this? Or do you have any other tips for when we experience this problem?
There's something I read about the wink. So if you ask a female to cough, you kind of get a wink. You can see her urethra. It helps that you just get like a little bit of a, there it is, but you've got to be quick.
The next question, I think that Gemma wrote, talking about, like I said, the micturition center to me has always been in the brain, in the pontine section, to do with the messages and everything like that, especially because you need the bladder muscle itself for the to actually contract, and then the sphincter muscle to be able to relax so that you can void. She's wondering about different treatment interventions to reduce the risk of trauma with a patient, especially if they are determined to go ahead with self-cathing. That is very dependent on the patient and whether or not you've got the option to be able to trial different types of catheters. And again, you have to what the patient is comfortable, even though you might think that something else is better for the patient. It's about education and letting the patient trial the different types of catheters. If they do have a history of strictures or false passages or anything like that, we do recommend that they use what's called a coude tip. It's got a little curve on the end, or the Tiemann's catheters, some are called. For those types of people that do have, some people, especially if it's a new spinal cord injury, some people don't even know that they've got problems in the urethra, and we don't know it until we try and do a catheter. And then we just get a handover from ED that it was a traumatic catheter insertion, and then we're caring for the patient with no real background of why it was a traumatic catheter insertion until we try and do a catheter change at a later date. So
why does the curve tip help? Why does it help? Sorry. What is it about the curve that helps? Sorry.
It will help direct it through, particularly if there's an enlarged prostate. It just helps direct it through, just being on a little bit of an angle. Doesn't work for everyone. The other catheter that works good too is the Speedy Cath Flex, because that has that little like drop of water, so it's got that little small rounded tip, and that I've had much success with that when we just can't get anything in, and we've tried those. So that's another one that works well.
Yeah. It all depends on the type of the patient. You do have to trial catheters.
Alison? You're muted still.
Go. Yes. Hi, it's evening here in New Zealand, and yeah, just to say that we have managed to be successful with the Vapro non-touch catheter with some tricky urethras as well.
Yep.
And not had to use a Tiemann.
Really is finding the right catheter for the person when there's problems with it.
Absolutely. Yes. Thank you.
The other thing I had written in my little notes, Tracy, was when people are having problems getting the catheters in for whatever reason, that's part of where the urodynamics, video urodynamics comes in, so that you can actually see what's going on. And I don't know what it's like for everybody else getting urodynamics done, in particular video. We have all the equipment here, but we can still only do video urodynamics one morning per month. We've only got one urologist, so I've had a few words with our head of unit just to see if we can start looking at having some other urologists come in, because those appointments are all booked up. We can't get our inpatients in, and we've got some people with really, really chronic bladder problems at the moment. Does any...
Sorry, Helen, I was just going to say, we sometimes don't even get urodynamics done until 2 weeks before discharge, which is
we discharge people and they haven't even had it done, the ones who are here the shorter time, and they're sometimes the ones that need it more because they have the trickier bladders.
Bladder, yeah.
If someone's going home with an indwelling with a view for a suprapubic, then they can be put on some oxybutynin or something if we're concerned about pressures, and have a catheter in, and they're safe with that until they can get the test.
Yeah.
No, I was just going to say, what's it like in some of the other countries for urodynamics or video urodynamics?
And also for the possibility of using different catheters. Do you all have access to different catheters, or do you just have one type?
We get different reps, and it depends on whether they will give us the catheters to trial. So sometimes it takes a lot to get the reps to actually give us the catheters to trial. So, and we pay for a selection of catheters to be able to trial, which comes out of the nursing budget.
What country is this, sorry?
I'm in Australia, in Brisbane, so that's could be completely different for Helen down south.
Yeah, where they just throw the catheters at me. But even that, with catheter selection, there's so many catheters out there, and I think well, I know I in particular through SA Health, I have to be very careful to not push someone to use a particular product. So I'll give them a range to try, and then it's their decision in the end. And I still tell them after discharge, try others if you want to. So it becomes their choice. I might recommend someone with a lot of infections try the no-touch one, because it'll reduce your risk. If someone has got a bit of a stricture or something, then the Speedy Cath Flex might be a really good recommendation. And we've had some of the bigger girls with larger thighs who have trouble catheterizing nice and cleanly, and something like the no touch is excellent for that, because it's enclosed and it doesn't matter if it's kind of flapping around and touching all sorts of things. There's just a comment in the chat box from Lin Chi, who's asked, can we also talk about trial avoid technique? So we can touch on that in a minute. And Lynn, in New Zealand, depends on funding stream regarding what is available to each patient. That's true everywhere, I think.
Definitely, if you're over 65 here in Queensland, we are very, very limited because there is no funding for those people that are over the age of 65.
Terrible, isn't it?
Should we move on to the next bit, Tracy? And that.
Which one's that one? Do you want
So,
Gemma? Do you want
yeah, let's pick another one from Gemma's and then we'll move on. I think the question about the sensitive to AD was a good one.
Yeah, I was going to say, again, that can be dependent on the patient. If the higher the level, if in relation to going to dysreflexia, because I can actually talk with this one at the moment because I actually have a patient who does go dysreflexic with his self-cats and may have a brain injury. And we have tried for several weeks now with education and medications. He is still managed to having really high residuals. Last weekend, he managed to have a residual of about 1 litre. And obviously went quite severely dysreflexic. And this has been occurring now for about 2 weeks. But again, it's patient choice. He is very adamant that he wants to self-cath. So we are trying with the safety mechanisms with regards to his education. So we're prompting him 4th hourly to do his catheters. We're using stockings to help with reducing the swelling of his legs. We're again talking to him every single day about how much he drinks. So it is a concern, but again, it is a patient choice if they wish to continue to self-cath with the dysreflexia.
And then trying to manage some of those risks where they are at high risk or they do get it. And if you can't get video urodynamics, it might be looking at something to relax the bladder. Oxybutynin or one of the other ones might help, and that really strict monitoring of the fluid intake and doing catheters on schedule.
We find that the patches, the oxybutynin patches, work better for these particular people because they don't have to remember to take a tablet.
True.
So, and he's also, we have him with some alerts in his phone that remind him again with both his fluids and his when he should be catheterizing. It's just whether or not he remembers to take his phone with him.
Lynn Chi has said that on the ward they have a long-term catheter. For those with an enlarged prostate, they always try to use a 3-way in case it later blocks. So that's good advice. And ANG in Thailand, they check bedside cystometry for patients once a year, according to the rights of the patient. Patients with a neurogenic bladder are trained to perform catheters on their own.
Yeah. We try and do those sorts of things as well. With us, we prefer, like even after discharge and everything, that they go for the kidney and bladder ultrasound, the KUBs, and they may not get the cystoscopies or anything like that. The only time that someone will go for a cystoscopy if they're going to have an SPC inserted, or if we have problems like stones and things like that.
Gus, did you want? Yes, Gus.
Hi, I just wanted to ask what was everyone's experience with recurring UTIs despite of like trying like flushes or citric acid flushes, or doing instead of 4 weekly, doing back to 3 weekly or even 2 weekly changes with regards of microdogs, like reducing the amount of heat pricks or ceasing heat pricks and then using microdogs for like that 2 week period. Yeah.
We don't use Hiprex routinely anymore. We have had people where they're getting those frequent UTIs and frequent blockages in particular. We try and get them a CT of their renal system, because that will sometimes pick up some stones that don't come up on an ultrasound. An interesting one that we had was a patient with a urethral catheter that was just blocking constantly, and he got to where it was blocking. It blocked more than once a day. It was really, really bad. He did have some stones that had been washed out. He then contracted COVID. He was really quite unwell, and he ended up on PEG feeds. So in hospital, he was on PEG feeds and no more block catheters. So I'm sure there's some correlation to what you're eating that we just haven't picked up, because it stopped. He did not get another block catheter. And this was someone who you couldn't leave him. You had to check his catheter hourly, and any uncertainty, flush it, and it was just blocking and blocking and blocking. It was awful. And he was a high level, and he would get dysreflexic with even a small amount. So that was just interesting. I don't have any kind of solution to it, but it was interesting.
I don't have any solutions for the UTIs. With the frequent UTIs, we look at everything with the hygiene, with their self-care. Sometimes it is a little bit about their self-care. We've had, again, we resort to the citric bladder washouts. We trial everything. Sometimes it's also the different types of catheters, whether or not we can get silver catheter, the silver coated catheters in. Again, it's a trial and error with regards to that. If they are constantly getting infections and constantly blocking, then like Helen says, they'll go for a CT, KUB, the CT scan, and they may, if it's repeated, then they will go for a cystoscopy so that we can actually see what's going on. Unfortunately, it's such a wait list for our urology team that you can, like I know with one of our patients, I think they had something like 5 catheter changes in a weekend, where even the balloon ruptures and everything like that. So we knew that there was a stone. We knew that there were stones in there, but he's still waiting actually to go for the cystoscopy, and that was 2 weeks ago. So we've done quite a few catheter changes.
It's good practice.
Yeah.
And it's really good. It sounds awful, but when someone's getting that dysreflexic, it is good training and education for newer staff to be able to manage that in a high pressure environment.
Situation. Yeah.
Gus?
Yeah, sorry.
You had your hand up again.
I think it was.
Oh no.
Oh,
it was
still up.
thumbs
That's
up.
okay.
Thank you. Yeah. I found that during summertime the period between changes was quite drastic, despite of the amount of fluids that we ingested. Yeah. Thank you.
Lynn Chi, I don't know, do you want to speak about the trial avoid technique as well? If you want to unmute yourself and just let us know what your experience is with trial avoid.
Oh, hello, everyone.
Hello.
Sorry, maybe I got a little bit background noise. Try to avoid, when I was working in a surgical ward, like they do it overnight, say 2400, and we start to try to avoid and see if the patient can avoid after 6 to 8 hours without the catheter. If they couldn't do it, and then we have to, like after 6 hours, I will already start to check with the doctor. If over 8 hours, they might start to have IDC reinsert again, and bladder scan as well. We have to do the bladder scan for 4 hours and another 4 hours. But if everything I have done, the heat, like some warm stimulation to the bladder area doesn't help. Water stimulation doesn't help. Bladder scan I have done doesn't help. I have to go back to the doctor, and they decide on whether the patient needs a bedside cystoscopy guided to insert or not. Depends on the background of the patient. Yeah. But I got a question. Recently, I got patient with got catheter removed, and she came with the bladder urinal retention, and then after we got like 1 liter drained out, and then the doctor said, "Oh, can you remove the catheter?" One of the junior nurses, she just straight remove it, and then later over 2 to 4 hours, the patient still didn't have any feeling to do a wee. But by the time I need to transfer the patient to another ward. So for this type of patient, they don't have any rehabilitation background or a bladder spasm background. They are normal bladder function, just need to remove the catheter. Do we still like do it clamped for 2 hours to test it, how they feel, and then remove? So what's the any suggestion you experts can give me, please?
So I suppose everywhere is a little bit different. What we do on my ward when we're ready for a trial of void or to start someone on catheters, we generally will start off with a flip flow valve. So we can just let their bladder fill up and see if they've got sensation, if they leak, all those kind of things. Then when we take the catheter out, we'll give them up to 4 hours. If they've not had any urge or any feeling, we'll do a scan and see what's in their bladder. And there's this really funny phenomenon when you take someone's catheter out and they decide they're not going to drink all day because they don't want to pee and have the catheter put back in. So it's pushing fluids with them too to get them to have enough in their bladder for us to tell. And then it's very much play it by ear. If they're voiding but having residuals or not voiding, we might do 24 to 48 hours of staff doing intermittent catheters on them and just see if there's any change or if they're ready to start doing it.
Pretty much the same. If we draw a trial of void, we'll do the same whether or not we need to teach them to do self-caths. We give them 4 and we will extend it up to 6 hours. But after the 6 hours, that's when we really need either the catheter goes back in or we teach. Occasionally, we've just done IMCs for a couple of days where it's up to the patient to decide if they want to learn. Sometimes it's still a little early for the patient to learn, so the catheter goes back in, and then we'll try at a later stage once the patient is comfortable with the idea, and they'll decide whether or not they start self-cathing.
Do other people do the same? You do the same, just put your hand up so we can have a look. If you do something different, if you want to let us know, we may learn something from you.
I never had to do one.
Annette, did you want to say something?
I've never had to do one.
Oh, okay.
So, yeah, ever yet.
Thank you, Annette.
Wasn't me.
Oh.
Wait for someone to go the other end.
Well, that wasn't me.
That's funny.
Has anyone else got a
Deci la întâlnirea asta Zoom cineva a râduit, dacă poți să-ți imaginezi. Asta care au astăzi.
Okay, if everyone can just remember to put their microphone on.
Niște australieni. Ăla cu... Ne-a trimis
I noticed
doamna Gina.
Oh.
I'm just trying to find out where that's coming from.
Da, săptămâna a 3-a, modulul 3.
I think that's everyone muted again. So, has anybody got a question they would like to ask? Or something that worries you with your patients? Anything at all? preferably related to bladder, but if you've just got a general question, that's fine as well.
I got another one.
Yep,
I
go
noticed
for it,
one,
Chris.
oh, I noticed
Follow
one of those.
question.
Sorry. Hi, Ruth.
Sorry. Okay. I was just wondering about neobladders. I've got a patient community that the catheter keeps popping out, and he uses like a very big bore catheter, and we just inflate the balloon with a little bit more than what the specifications are, but it just keeps falling out with people pulling them. I was wondering if that's a method that we can keep it in apart from anchoring it somewhere, or maybe is there like a product out there that has like a bigger size balloon?
We've had a couple of people like that, and we just get kind of a catheter with the biggest balloon that we can, but they really need to see a urologist and find out what's going on, because for some reason they've got a very loose sphincter. It doesn't happen often, but it does happen, and usually these people, without the catheter, they'll just be constantly incontinent, but the catheter might stop some of the incontinence, or they're incontinent regardless. So they're ones that really need some urology advice.
We've got one actually at the moment, one of our vent-dependent patients. She had a SPC inserted, but she continued to bypass urethral. So we had to put and we previously to the SPC insertion, we were using the large gauge catheters with the large balloon. However, she was still able to dispel those catheters. So she's actually going for a procedure in theory. We're still not sure if it's been scheduled, but on Friday she's going to have some Botox to her bladder to help, because the spasming of the bladder, but they're also doing a filler. We thought initially that maybe they do a urethral sling, but they're talking about a filler with the Botox to see if they can control her leaking and bypassing, and the fact that she was dispelling those catheters.
Wow. Let us know how that goes, Tracy.
And we're just hoping it actually goes ahead.
Yeah, well, there's that too. I haven't had any more questions pop up.
I've got one actually.
Yes, go for
on
it.
on those videos that we watched, they did a male catheterization there, but they did it. You're supposed to put the penis up, aren't you, when you do a male catheterization? They didn't do that. Did you know? What we just was on the course.
Yeah, I, to be honest, didn't watch that video. I did watch I watched the suprapubic one because I thought, oh, that'll be exciting, and then watched them waving the catheter around everywhere. But
I watched that one because I don't do them very often, really, the urethral ones, you know.
Yeah.
But, I always learned that you were supposed to put the penis up, but the nurse didn't. It was just flaccid and she put it in.
Yeah, and the sterile gloves that were, yeah. We have videos, our hospital produces videos, and we still go by the full sterile technique with the full kit, and the sterile gloves and everything. I was a little surprised when I watched those videos because I hadn't actually done the bladder one for a very long time.
Yeah, that's why I watched. Yeah, that's why I watched. And I'm right, aren't I? That's how we normally do it. But she didn't do
I was surprised that it was just, yes, I'm used to a big kit with kidney dishes and syringes and everything like that, which is, I think, I'm not sure if I should have a look at mine, whether I said to refer back to whatever your local procedures are and everything like that. That's one of our biggest things is, like I say about the hygiene cares and everything, we're still very sterile when we do our catheters, even the IMCs or the clean self-cats, we're still really quite particular. We've had, which I was thinking about your research and everything, we've had a lot of epididymalcitis recently. with our new injuries coming through. We've had, at one point, we had 4 patients. We have a 40-bed unit, and we had 4 patients that had epididymochitis, and none of them were in the same cohort. Like, yeah, it was just strange. It was strange because we don't record CORTI anymore like we used to on the database. So I don't know.
Does everyone know what that is? Do you want to just explain what, I can never say the word properly. Epididymochitis.
Epididymochitis. Well, in the normal people apparently refer to it as red hot rocks. The testicles are all enlarged and red and swollen, and in theory you're supposed to put a sling around them. And the gentlemen get quite, well, they can go dysreflexic, and
they get very sick with it too. Yeah.
Yeah.
There's a question here from Lynn Chi. She said for suprapubic patient, it is common to have bacteria colonized, and that's the same urethral or suprapubic. How much abnormal do we need to treat it, as sometimes there's no signs or symptoms, or do we just maintain good hygiene to clean the insertion? So we tend to, we know if there's something foreign in the body, there's going to be some bacteria there. We tend to not treat it unless there's some symptoms. And that could be fever, chills, increased spasm, leakage, we would class as being a symptom. But if it's just you do a random check of their urine and there's bacteria there, we tend to not treat them to try and stop some of the resistant antibiotic resistance.
Same here.
And I think that's fairly common. I don't know about in other countries, but I think we've scared some of the other countries. They don't want to talk to us.
It's the same in Denmark.
Yeah.
Tracy, I just have a question. You said you had videos.
Our hospital produces videos for catheter insertion, female catheter and male catheter, and we also do a video for the suprapubic.
Do you have those videos? Are they available for everybody? No, that's a shame.
Because I belong to Queensland Health, they are actually allowed. And Queensland's a very large state. And that's what I do a lot of, because some of our patients can take 3 months before they get to us. They can be in far north Queensland, which is an 18-hour drive. So it's benefit like the nursing staff up there that I'd send them links of how to do that, because not everyone knows how to change a catheter or to insert a catheter. They don't do it often anymore.
And I would say that the content of the eLearn SCI is something that can be improved over time. We haven't produced that material for this MOOC, so we just use it. But we should definitely at some point look at the content and see if there's anything that we need to replace with better material.
Yeah.
So if you have any good material, then let us know. Yeah.
And then there's a question from, I think it's from Lynn again. How may I accredited to insert or change suprapubic in SA? That's very dependent on where you work, particularly for men. So for women, any nurse should be able to change a urethral catheter, same as suprapubic one. They're one of the easiest to change anyway. There's just a few things to monitor. For men, it's a bit different. So because we're in a spinal unit, our nurses are allowed to change male catheters, but we do go through quite a strict observing a certain amount, then being watched doing them, and then have a final sign off. And those nurses won't change male catheters outside of the ward unless it's with a spinal patient that we're familiar with, because we don't know all of their background. But it would be very much dependent on where exactly you work and what the guidelines are.
There's a lot of things that can go wrong with the male catheter. Which,
Have a look at that video. You'll be interested in it then, the male one.
Yeah, we're very particular because you've got to have the penis at 90 degrees and you don't force. That's a big thing. You do not force the catheter. And I'm also very adamant about you insert the catheter. There's no tugging. You have to wait for the urine to drain, but in theory, you should insert the catheter all the way to the wide junction.
Okay.
And allow for urine to drain. Then you will blow up the balloon, and then you let the catheter relax. There's no tugging or anything. Anything like that, especially with spasms, can actually cause the trauma, which is why I think there's some issues there. Like Helen says, we're very strict with how we do male catheters.
Yes. But the nurses are very good at it.
Yeah.
Some doctors are too, but they just don't do them very often.
They don't do them often.
No. And that's one of the other, like I said, with someone blocking catheters frequently, that while that's an awful thing, it does give a lot of practice with catheters, catheter changes.
We've had a lot of new staff. We've hired 30 new staff in the last 6 months. So it has, most of them are catheter competent.
Has anyone else got something they want to ask? If you just pop your hand up for us, down at the bottom where it has reactions, if you just put your hand up.
I'm sorry, I'm looking on it. Oh, no. I can't find it.
That's okay, Annette. You can just speak.
Now, in Bladder, in that Bladder one we did last week too, I couldn't access those 2 research papers. Did anyone else have problems with that? No,
I haven't tried. I did have trouble. There was a link to something with the general kind of essentials bit. There was a link to something as well that didn't work. So we'll feed that back to our higher level colleagues back at ISCOS and see if they can fix some of that.
The UTI one.
It was actually, yeah, there was 2 in the one on the right, and I just sort of gave up after that. Something else happened on the left, and I just couldn't print them out either.
No.
If the links don't work, you might be able to just Google them and find them that way. No?
The UTI one, I think it was on the right-hand side when you go through the screen.
Okay.
And I think because it was based in America, so that's one of the reasons they don't allow access to that one anymore. So whether it must be out of date or under review or something. Because I didn't have clearance.
Rita, you've popped up. Did you want to?
No, I
just want comments.
Just wanted to say that I too had difficulty getting the UTI one. I did manage to get the one about the management and prevention of the European and Asian guidelines. I got that one, which is excellent. But what I had a problem with is the self-assessment. Couldn't get 100% if my life depended on it. And I copied my answers, and I copied their answers, and they were exactly the same, but they would only give me 80. So I have to live with that.
Yeah.
But I'm looking at them, same answers on both, but nah. All right.
It must be another glitch in the system. Mine told me I tried 3 times for that, and I only did it twice. So,
but I got 100% for all the other. Well, on the other one, so you know, it's okay. I can handle it.
You can handle that good. Rita, where are you from?
I'm from Queensland. I'm
well.
from one of Tracy's. One of her. I was almost going to say one of Tracy's. Nurses that works in the spinal unit, and I absolutely loved the whole program. It's excellent. The information, you know, I've learned an awful lot, and I have been working in the unit for a couple of years. So it's been all of the modules have been fantastic. So thank you all very much for that. Yeah.
We've got
just maneuvering.
glitches with the
around screen.
links, but it's a learning curve for all of us.
Can we photocopy the modules after we've done them? Should we be able to, or we can't?
What do you mean photocopy the modules?
Yeah, so I've got a hard copy I can put in the office. Like, can we do that, or we can't?
I don't know
Anyway.
how.
You can print them out.
You can print them
Well,
out.
I couldn't figure out how. Like normally I could print
On
stuff,
the very
but
bottom,
Down the
there's
bottom.
a bar, and
Yeah.
it says if you want 1 slide per page, I think then 6 slides per pages, or you can have. I went maximum. I think I got about. Hang on. 1, 2, 3, 4. Yeah, 6 per page, back and front. So I didn't have an enormous amount of paper.
So
But
the
yeah.
answer is yes, I can do it. Yeah. Thank you.
Now I know whose printouts they were on the photocopier, Rita.
Now there's also a question how long the course will be open from missing a few weeks. Once we get to week 5, we're going to keep it open for another 2 weeks after that, so everyone can catch up and finish all of the modules off. So, and if you're having problems at that point, just make sure you let us know in the first extra week before we get right to the end, because I think once we closed it, I don't think we can open it again after that. We kept closing and reopening registrations, and we've still got people trying to register, but we can't do any more now. So they'll be in the next one. The next one will be some different topics.
When's that?
I don't know, Annette.
We just need to take a break after this.
This one took, what was it? It was 2.5 years to get this up and running.
Wow.
Next time it's going to be easier. Yes, it took a long time,
Content's
this one,
great.
but
It's really good.
Yeah.
Next time
And
it's
the-
going to be easier for us. Yeah.
I think the physios will do another one later this year. So we'll probably be looking either end of year or early next year again. But it's
Great.
good, and yeah, it's such a good way to get the basics done again.
Yeah.
I've got a question. Maybe advice could be given. I've got a customer that's not a spinal, but it's Huntington's. So any too much stimuli, the person's sort of muscles start sort of contracting, and it involves like the respiratory system and everything. So if there's too much stimuli during a urethral, we use the supracath because of the continuous like problems with bypassing and just blockages. So we use a urethral that is quite thick, the lumen, and that's the only way that we can keep him at home rather than off to hospital every other day. The problem with that is that it's so thick that it's kind of like a difficult insertion for the urethral. So we use a supracath that tells us the amount of centimeters to go in so that we don't actually poke the bladder and the person stops breathing because of too much stimuli. So we usually insert it 1 or 2 more centimeters down to make sure that's in there. And you were saying that usually you would opt to insert it all to the Y junction. I was hoping maybe there'll be some tricks that you'll be able to sort of tell me about on sort of the same sort of conditions, maybe.
Is that urethral or suprapubic?
It's urethral. He was for non-surgery because of the developing condition.
Yeah. Not something I've come across. You're going to have to research this one, Gus, and tell us.
That's okay. Yeah, we've tried a number of ones. Ones with blunted edges, sort of like the Uralene or the BioCath ones that have the different sort of material that it might slide a bit better.
Yep.
But it would just end up clogging up, and then we'll have to either take them to hospital or get the family member to take it out. We sort of had this. I had this sort of consult with urology in where I am in Perth, and urologist nurse sort of gave me some advice to sort of use a BioCath, the silver coated ones, the barred IC, and instead of just letting the tip continue, it was sort of like an advice to use sterile scissors to sort of cut the end and reinflate the balloon to make sure that it was inflating. But then I was like, how is that going to be done in community? Because where I work is community, so I haven't really touched it because I don't want to sort of put it like, if it makes sense, just try to protect my registration.
So
but that is
cut the catheter and then put it in and inflate the balloon?
Yeah. So the very end tip of it, to cut it so it ends up being, instead of the blunt edge, it will sort of be an open-ended end to sort of make sort of like a biocar, like a sort of open rather than blunted.
I'd be looking for a catheter that is open-ended rather than making your own. There are some out there that are open. Yeah. That because I think if you cut it, if you get a little minute piece of that material comes off in the bladder, then that's just going to be something for stones and crap to grow on. But there are open-ended ones. We use, for indwelling catheters, we use the Raylene catheter all the time. It has a bigger inner bore, so you can keep to the same size. 14 or 16s are what we mostly use, but the inside bore is a little bit bigger, and I can't remember if that's open-ended or not. I can't remember. Too old.
The only open-ended ones that I've been managed to find out there are supercath ones.
Yep.
Is there any other manufacturers?
The supercath, yes.
Yeah.
Yeah.
You could just Google and look, because there are so many catheters. But yeah, I would advise to not cut the tip of the catheter and then put it in. If something were to go wrong, then you're putting yourself on the line. So I wouldn't do that. If the urologist wants to do that and put the catheter in whenever it needs it, go for it. But yeah,
that's what I said. Thank you.
And we'll delete that bit from the recording. No, it was a hypothetical question. Yes.
Yeah. But there's something I've been asking all around, and I just want to ask quickly. Is there anywhere in the world now that takes our expired catheters that are unopened, that used to be? It just seems that we're just chucking a lot of stock that's really good, but it's just expired. It's terrible. And I can't find anyone that's interested in that anymore. Anyway, that was...
Years
I
ago,
think a lot of
sent stuff to Nepal after one of the earthquakes. So maybe there's something over in Syria and Turkey with their earthquakes, because they would have lost a lot of equipment.
Yeah. So
I think there was a lot of places though were getting huge amounts of things donated that were expired, and they were having to then store them or dispose of them.
Okay.
I don't know what organisations, what is it, Medicines, that doctor one. Yeah.
Sans Frontiers.
Any of those kind of places might know. We used a lot of expired stuff when we had the bushfires here, and there was all the poor koalas and things were injured. So we packed up a whole heap of expired stuff because I just wanted anything for those animals. It's where I cleaned out all my cupboards.
Okay. We need a world autoclave.
We could invent one.
One in Switzerland or something. You send all your stuff there and they do it.
So if anyone's got any last minute question, please pop your hand up now. Otherwise, we will say good night or good morning or good midday, depending where you are. Next week, we are looking at bowels for our topic, and Veronica will be hosting that one.
Bowels now? Oh, next week. Oh, this is okay. Sorry.
Yeah, so we're doing the bowel unit now, but we'll do the discussion on it next week.
Sorry.
We're just kind of a week out of whack.
Sorry.
I just have to check the times with young Paris and see if he's open to helping us with this out of hours, so I'm sure he will. Well, I will say for me it's sorry.
Thank you.
Thank you everyone for joining us. I hope you enjoyed it. Yeah, Paris is just saying he'll have to log off in 5. He'll stop recording and send it to me.
And we will send
yeah.
you the link for the next MOOC with the letter for next
Yeah,
week.
so
Or for the next Zoom meeting. Yeah.
I can see Lynn's given us a thumbs up. Thank you, Lynn. Great. Keep working, everybody.
Thank you.
And we'll say good night, bye, good morning. Do the other SIG members want to just hang for 2 minutes? So Randy and Tracy and Veronica, thank you, everyone.
I can go.
Thank you.
Bye.
Bye.
How do I go? Oh, I go leave. You got it.
Good night, Annette.
Good night. Thank you.
I did just see there was a couple more waiting to come in, but they were right at the end, so we unfortunately missed them. Still a couple of people trying to log off, I think. Unless they got bored with us and walked away. That went a lot better. I was panicking this afternoon, thinking no one will join in, but they have.
I had to eat a Kit Kat while I was waiting.
Paris, can you stop recording? Is that possible without ending the meeting, or?
He did say that he would stop recording and we could keep on with the meeting.
But it looks as if it's still recording though.
I don't know where to see that.
You
It
see
looks
that
like it
in
stopped.
participant. Okay.
Well, yeah, I'm not sure.
If you look in participants, it seems like it's still recording. No, I can't see where to do that. If you look in the bottom, you have participants. If you click on that, then it will open. And then you can see the participants.
Oh gosh, there's somebody trying to join right now. No, I can't. I'll just send a message to these people waiting. They may have got the times wrong.
It's possible that they are not on their places, so they can't stop it.
Yeah, I don't know. They should be able to leave. I don't know how to remove people.